Okay, so you're able to see the screen, Dr. Fatima?
Yes.
Perfect. Okay, so this is your first task, and this is the only slide for you to go through. And I'm going to start your 2 minutes timer. All right, we'll start the station, Dr. Fatima.
Hello, I'm Dr. Fatma. Am I talking to Miss Jean Louis?
Yes, doctor, that's me.
And should I confirm your age as 65 years?
Yes, that's right.
I'm really sorry, but the consultant you were previously seeing is busy in other case, and I'll be in his place for now. Is that okay with you?
Yeah, fine, doctor, no problem, as long as you answer my questions.
That's great. So you went a total abdominal hysterectomy and a bilateral salpingo-oophorectomy a while back. Do you know what procedure that was? And did the consultant explain everything to you?
Yeah, I had a cancer, so I had
Okay.
to undergo womb surgery.
Uh-huh. So you were on board for a stage 1A endometrial cancer?
I don't know about the stages, doctor, but they told me it is some early cancer.
Okay. As a consultant, must have told you that before surgery you were diagnosed with stage 1A endometrial cancer. That is, the cancer was limited to your uterus, and it had invaded only less than 50% of the innermost layer of the uterus. Are you with me?
I think so.
Okay. Uh, After of course, we sent the specimen, the uterus and ovaries that we removed for histopathology, which is a procedure that we have to follow after we're done with the surgery, and it came out to be much more invasive than it was before. Do you want someone to come to be with you
Basic?
while I discuss this?
I'm not following you, doctor. What are you trying to say?
It might be slightly worst stage than you think that you
Worse?
was in. uh, I'm sorry, I should rephrase myself. It's at a it's invasive stage than you were predicting it to be initially.
Oh my
So
God.
would you like someone to be with you before I discuss the histopathology
No,
report with
I'm
you?
alone, doctor, but they told me that it's an early cancer. What are you trying to say?
I'm
I
really
I
sorry
went
that you. I'm really sorry you're feeling really agitated. I would like to call my nurse to sit with you. Would that be okay?
No, I don't want anyone, doctor. Before the surgery, they told it's an early cancer. And are you trying to say the MRI that they did was wrong?
I'm really sorry that you're feeling really upset right now with the information that I'm giving you right now. But the thing is that whenever we perform a surgery, we do send a specimen for a microscopic examination, and it actually shows us the stage at which originally is. We can't really predict that with the naked eye. What your consultant is was perfectly fine because initially on just the tests that we conducted and the radiological findings we found it to be at a very early stage. But it is at a stage which is treatable. And of course, we're going to make an effort to to make a whole team of experts who deal with the case. Is that okay? Does that make you feel better?
Are you trying to say that, I will need some more treatment now?
Unfortunately, yes. The stage that you are at right now, you might need another surgery as well.
Another surgery, doctor? Doctor, are you kidding me? I just had one surgery. It was a major surgery, and I'm just recovering, and you're saying I have to undergo another surgery?
I'm really sorry, but I hate to inform you that we might need another surgery, which of course your original consultant would talk to you about. At the same time, we have to give you a form of external therapy, whether it is it's a form of it's called brachytherapy, and it's insertion of chemicals into your body through a probe in the vagina, and it has a local effect and will probably help you not go through all that you have to go through in the chemotherapy. Like it won't go systematically. It'll just a local treatment. Are you with me?
Oh my God, doctor, this is not something I expected from all of you.
I'm really sorry that you had to go through, Miss Jean, all of this, but unfortunately, this is how we have to treat an invasive cancer or a cancer that is at a later stage than you were at initially. Do you want to talk about anything else?
No, I don't know. I'm just confused.
Okay. Should I explain to you about further details or the further procedures that you have to go through?
Okay, fine, doctor. Just tell me, I'll take my own time and decide about this.
Okay. Would you like a glass of water?
No, just tell me, doctor. So what are we supposed to do now?
Okay, since we are talking about the cancer, and it's a stage 1B cancer, and at the same time that we did perform the histopathology on it, we also did a molecular diagnosis, which came out to be something that needs immediate treatment. All right. We need to have a team of experts, including the oncologist and the surgeon and the original consultant who performed the surgery on you as well, and the radiologist and the histopathologist as well. So this team is going to decide how to take your disease, treat the disease furthermore. Are you with me?
Yeah, okay.
Okay. Talking about why I mentioned that you might need another surgery is because we need to remove some lymph nodes which were initially not removed because we considered it to be at a stage that was less than it is right now on molecular biology.
What is that, doctor, now?
Uh, when the cancer involves your uterus basically drains blood and some into different parts of the body, including the arteries and veins, and there are other systems called as lymphatics around the uterus. And there are some nodes that screen those blood, and we need to remove those because they might contain some cancers from your uterus that might travel to other parts of the body. So we need to remove those nodes so to as to hamper its spread in the rest of the body. Do you get me?
Oh, okay. This is all too scary, doctor. Why didn't they do it at first place then?
Because initially we did not know that whether it was a stage 1A or a 1B, and we got to know it through the histopathology. And sometimes you don't see things initially on radiographic imaging or through the tests that we conducted previously, and you come to know about it when you take out the tumor and you put it under a microscope and you see the cells. All right.
And this is too overwhelming, doctor. Then how much time I have got? Am I gonna live with, so much of advanced cancer?
Oh, yes, yes. Don't worry about it. The overall 5-year survival rate is approximately 80%. And at the stage that you are at, it's probably going to be like 95%. So you have a very good chance of survival, I assure you.
Okay, so anything else I should be aware of?
Yes, the good part is that the tumor is still confined to your uterus, and though it has invaded more than 50% of the innermost layer of the uterus, but it was still confined to it. And there are least chances that it's going to spread too far, and you're going to recover really well if we give the form of chemotherapy, that's brachytherapy. And you're going to really respond to it. You want to talk about brachytherapy more?
I don't think I'm up for it, doctor. Let me just discuss with my partner.
Okay. You have plenty of time to discuss it at home, and then you can get back to us whenever you want. We can answer all your questions.
Okay.
Um,
Anything else you want to add?
I'm lost at words. I think I'm done.
All right. Okay, so you still had like 20 to 25 seconds left. Okay, well
Okay.
done. So, what is your reflection, Dr. Fatima?
I guess I wasn't really clear about brachytherapy. Maybe I jumped on a few things, but
Okay.
I but this is my first onco session that I'm attending. So um,
Yeah, it was a fair attempt. So, since you have been practicing, you started practicing now,
yeah.
so you will get a hang of it. No worries about it. So, I will hear from the group that what are the points that Dr. Fatima did really well, and what are the areas for the improvement, if at all you guys would like to add something. Charlotte, anyone wants to say something? Go on, guys. Please make it faster so that we'll go with the discussion.
Ma'am, overall, her presentation was very nice and
Mm-hmm.
she was very empathetic towards the patient. But many of the time she was using medical jargons. So that was quite difficult for as a patient to understand.
Mm.
So
Like
this
what?
thing,
What are all the medical jargons you picked up?
endometrial cancer and
Mhm.
many of the things in between I was actually I'm today busy in between I was listening. Yeah, whatever I
No
got, I
problem.
understand.
No
Yeah.
problem. Yes, yes. That was a good thought process. So, anybody else who would like to add? Come on, guys. Dr. Bhuvaneshwari? No one? Dr. Nabila, Nancy, Rabia, Noy, Zabe? Anyone wants to add anything? No one. So, how am I going to conduct today's session? I don't know. No one is talking today. Okay. So, as far as your task is concerned, you attempted really well. Okay, you knew most of the stuff that what exactly we are gonna go about it, but the structure was lacking. So here, when it comes to the simulated patient task, did you read the domains, Dr. Fatima? What domains you have got in front of you?
Yes, the information gathering,
Yeah.
communication with the patient,
Mm-hmm.
communication with colleagues, patient
Yeah.
safety, and applied clinical knowledge.
Yeah. So what was missing from your discussion altogether?
Communication with colleagues.
That you told that who you are going to involve as a team of specialist doctors. Communication
Okay.
with the patient you did. Patient safety and applied clinical knowledge, nearly you covered. What are we gonna do? So information gathering.
Yes, I did not ask about why she went in and
Yeah, I mean, there was
BSc.
history was entirely missing in the entire
Mm-hmm.
discussion, right? So I
Yes.
was wondering that why you missed that structured approach in here. I mean, I was thinking that you're not following the template. That's okay if you don't follow the template, but I was
Mm-hmm.
hoping that at least after discussing the results, you will come at some point of time and ask the history which are necessary in here, right? So you always have to look at the domains that they are asking here. So you have to cover all the domains which are important because they also have got its own marks in the exam. Okay. So your introduction was good. You apologized that the consultant is not available and you will be continuing the consultation. You sought permission, which was good, which is important point when it comes to communication with the colleagues, because it is clearly mentioned that consultant is delayed in another consultation. So you apologized and you sought permission to proceed further, which was good. And then all of a sudden it became very abrupt with a lot of medical jargons. I mean to say, you started saying like you underwent total abdominal hysterectomy with a bilateral salpingo oophorectomy because you had you did not say endometrial cancer, you said THBSO. And then you also asked like whether anybody has discussed with you about the surgery, what was told to you. It became very abrupt. So I think this I have been telling from many classes that have that situational awareness that which patient you're going to talk to. She just had a surgery, and that too, it was a difficult diagnosis of a cancer. So you're meeting someone, so you cannot just go abruptly and ask, as if nothing has happened. Okay, it's important you demonstrate that empathy there. Okay, that I'm aware of your situation. You recently had such a such diagnosis. You underwent such a such a surgery. How are you coping? How are you managing with all of that? Do you have enough support? That's very very important when it comes to the communication with the patient, as well as this is something which is important for the lay examiners as well, that whether you have that situational awareness, whether you are demonstrating that good empathy or not. Do not jump into the facts which are given to you there. Okay, and avoid medical jargons. There are a lot of medical jargons like total abdominal hysterectomy, bilateral salpingo-oophorectomy, endometrial cancer, stage 1 cancer, and invasive cancer. All those were bit abrupt. And then you started explaining everything, that were you told that what stage of cancer you had, and you immediately jumped into that, to give her the giving her the bad news that this has been spread. It has invaded almost more than half of the myometrium. So this was bit abrupt. It was okay even if you have done the discussion of the results. That's fine. I'm not saying that you should have gone with an information gathering, but at least you should have set this, scene. You came to that later by asking that, I will ask my nurse to be with you. Do you want someone to be with you? All that came later. So somewhere, do you think that it was a bit abrupt giving her that bad news?
Yes.
Yeah, so that's what I'm trying to say in here. So first you inquire, once you apologized that the consultant is not available, demonstrate empathy and ask about that emotional well-being. That is very very important in here. Okay, so just a minute. Yeah, so empathy is very very important. Then you ask about the recovery checks. So how is she doing? Does she have got any symptoms like fever, discharge, or any bleeding, anything like that? So whether how she's moving around. So those are the recovery checks you can ask. And then confirm the purpose of the visit. Okay, so that you underwent a surgery and today you're here to discuss the biopsy results. Is that right? So then baseline understanding. So what she has been told so far about the surgery findings, and whether she is aware of any stage of cancer, all of that, okay, and whether she has got any particular concerns or any expectations from today's discussion, and then you move towards your information gathering. So it's not like she's very much hurried or anything like that, that she wants to know her results. So you can take permission and you can ask the information gathering, not a problem at all. Okay, so the information gathering was entirely missing. Okay, so the basic questions. Okay, how is she doing? Whether she has got any pain, bleeding, discharge, fever, any wound problems, and then whether she's mobilizing, eating, drinking well, and any bowel bladder symptoms. Those are the things that you're going to ask. And, don't mind me bringing back all the old memories, but, what symptoms led to this? So she had a postmenopausal bleeding that was investigated, and later it was suspected endometrial cancer, for which she underwent surgery. And then past medical conditions, whether she has got any significant medical conditions. And it's very, very important to know whether she had any other cancers. It could be a bowel cancer, it could be ovarian cancer, and a family history of ovarian, bowel, womb cancers. So why are we asking this question to her? Why are we particularly worried about personal or a family history of bowel, womb, and ovarian cancers? It's already given there, just to
Yeah,
reinforce
because of
things.
Lynch syndrome.
Yeah, so she has got MMR deficiency. If you look at it, they have given P53 in the molecular typing. They have given P53 wild type, and then they have got MMR deficiency. So when they have a MMR deficiency, there is a possibility that there could be an inherited cancer. It may not be apparent in this age group, but still it is worth asking about these personal and family history of bowel, ovarian, womb, other cancers. Extremely important patient safety points, because we may have to screen her, and if that comes positive, then we have to screen for other doctors' sons she has got. Okay, ask about obstetric history, whether she has got any children, and then ask about the BMI. She has got a BMI of 40. So again, it's important patient safety point. The reason being, this condition can come back. Now it's 1B. There's a slightly higher risk of recurrence compared to very early cancers when there is no myometrial invasion. Since there is a myometrial invasion in here, this condition can come back, and that too without an additional treatment, that risk increases. And if you don't emphasize on the lifestyle modifications, okay, that she has to have a healthy BMI and exercise, all those things are very, very important patient safety factors, and you have to educate her, and that's how we look at it. So you did not ask about the BMI. That's because you missed the entire information gathering and you could not address that. And social history, like whom does she live with, whether she has got adequate support. Sometimes these old age women will be living alone, so you may have to look into the social circumstances as well, put her in touch with GP, social support, community nurse, and things like that, where they will take care of them. So they may have some financial difficulties, ask that question as well, because at times those were the scenarios as well, which were clubbed, that they used to live alone, and you have to look into that as well. And how she's doing otherwise emotionally, how she's coping, whether she drinks or smoke, those are the things. And then do an examination. Because of BMI of 40, it's important to do examination along with that blood pressure, feel her tummy. So those are the basic things. Always remember, information gathering means it's the history and the examination wherever it is applicable. Okay, so family history of other cancers is important. BMI becomes important. Checking her blood pressure using an appropriate cuff size because of her BMI of 40, which is important. You understood now, Dr. Fatima?
Yes.
Yeah, so don't forget, there will be some patient safety points as well from the information gathering. Only by asking questions you will be able to address them. Okay, in the management part, you should not be missing that. And as far as, yeah, just a minute. Yeah. So as far as the results is concerned, go step by step. Even if you want to do it just in the beginning, even before information gathering, it is fine. But do it as a breaking bad news template. Okay, offer support. Check that I can see that you're alone. Would you want me to call one of our nurses to be with us? Have a lot of information to give you. Okay, and then you give a warning shot that, okay, I have these tissue results with me. Some of the information, it might feel a bit complicated, but I'm going to explain everything step by step in here. because you're going to explain the staging, you're going to explain the molecular typing. So this is all very overwhelming for them. So it's important that you tell them that I'm going to break it down, okay, and tell you in a simple terms. So it was okay for you, but it was just that the structure was a bit altered. You knew the Breaking Bad News template, but then you came afterwards. So instead of that, you try to bring that in the beginning, okay, and then you try to use the diagrams, Fatima. Okay.
Mhm.
What happens is that even if you miss some, even if you mistakenly bring some medical jargons, at least it will be compensated. If the examiner is finding you, okay, she's at least trying to explain it in a diagram. It doesn't have to be like you have to draw it neatly and show. You just have to enact. Okay, just
Mhm.
scribble it and show it, enact it in the exam. Okay, that I'm going to draw this and show you that this is your womb and these are the tubes and ovaries. So before the surgery, we thought the cancer was very much limited and superficial. I mean to say, it was only confining to the inner lining of the womb. So the cancer, now the tissue results have confirmed that it's an endometrial cancer. I mean to say, the cancer arising from the inner lining of the womb. And before the surgery, we thought it was very early cancer. I mean to say, it was only superficial and limited to the inner lining of the womb. However, after examining the tissue that we removed after the surgery under microscope, we found that the cancer had grown deeper into the muscle layer of the womb than expected. You can see here. So change your variation in the tone as well when you are going to give it. Don't give it like how you're talking from the beginning, because this
Mhm.
is some critical information. So just lower down your voice and just say that, this is appearing that the cancer has invaded more than half of the muscle wall of the womb. And just pause. Okay, you have given that information that it's a bit upstaged now. It's not the early cancer. It's a bit, has progressed and it has invaded towards the muscle layer of the womb. And then she would say like, oh my God, that, how I replied to you that, they told that it's an early cancer. How is it different now? And was the MRI wrong? Just pick up the questions that she herself is saying and you can rephrase the same thing. Was MRI wrong? Not necessarily, isn't it? Because the MRI is the best investigation for that matter. Before surgery, we offer to any women with endometrial cancers to identify to what extent the cancer would have spread. Yes, but sometimes it cannot pick up those very small, microscopic areas accurately. Okay, that's very, very important. You tell her that I know this is very distressing for you to hear. I know you look quite distressed hearing this, that you're getting to hear a slightly different information. I'm really sorry to, for you to giving you this news. But MRI was not necessarily wrong. MRI gives us the best estimate of how deeply the cancer must have grown, but it will not pick up very early, small areas accurately. So that's why we always remove the tissue after the surgery and examine it under the microscope very carefully by the tissue experts. That is the one which is giving us the definitive information. This you almost told, Dr. Fatima. I was happy that the MRI was not wrong. I know you were upset. All that empathy part was very good, and you also told that the tissue sampling is the one which is the definitive diagnosis for us, that will tell us in a better way that what is the information that we have got. All that you did very well. Okay, and somewhere I felt that you should have told that yes, cancer has spread from 1A, it has become 1B now. That is almost more than half of the myometrium is involved, but it is still limited to the uterus, isn't it? So, who is going to tell her that information? So, you kept saying it has abruptly, like it has got a worse prognosis. It has got, it is very invasive. Why did you think that it is more invasive now? It is still early cancer. 1B is still an early cancer, right? Stage 1 and 2. So, what made you think it's a worse prognosis?
Um, because of firstly, because she did not get the
Yeah, firstly?
because of the history, like the maybe the Lynch syndrome. It might be primary somewhere else, and it's like
We don't know. It could be associated with the Lynch syndrome. We cannot
yes,
say it with certainty
definitely,
because we
yeah.
don't know, right?
And
If you're talking about P53, are you thinking because P53 is there, so that's why you are thinking in terms of aggressive?
yes, yes.
Okay, so basically here, if you look at it clearly, we say that it's a P53 expression is wild type. It
तो
is
बताइए
not
मैं बाबा से
P53
चेक करती हूँ पापा ने
abnormal.
कुछ कहा तो नहीं
Who's that? Please mute yourself, whoever is joining. Nazia Hassan, please mute yourself, dear. Yeah, thank you. So it's a P53 wild type. Okay. It's not P53 abnormality. So that was the catch. And people were confused in the exam. Okay, Fatima?
Okay.
So we will come to that discussion later. So when P53 wild type is there, it's a normal type. You don't have to worry about it. We should only think about the MMR deficiency. And when we have got a MMR deficiency, it usually puts them into intermediate risk. So you will understand in a more better way once we discuss everything when we do the activity later. So now it is the other, you should have reassured her that it has spread to the more than half of the muscle wall of the womb, but it does not necessarily mean that it has spread to the rest of the body. It only means to her that she would require an additional treatment because slightly it puts her at a higher risk of recurrence. So to prevent that from happening, we have to advise her some adjuvant treatment. That was correct for you. So when it comes to the adjuvant treatment, I'll come to the adjuvant treatment later. Even the molecular typing, you have to just say that we have got some additional tests, okay, on the cancer cells after the surgery. And this is in order to guide us. So why do we do the molecular typing? Anyone? What is the need for doing a molecular typing? You have got an anatomical staging, you have got histopathological diagnosis. So what is the necessary for you to do the molecular typing? Why are we complicating things in here? Anyone? Please talk now. We have to move forward. Dr. Soumya? Dr. Noy?
Is it our genetic disease?
Sorry? Yeah, Dr. Hamada?
Other genetic disease?
We are not able to hear you.
Genetic disease?
Genetic disease.
For grading the disease.
Sorry, I can't hear you. Just put it in the chat box. Okay, yeah. Dr. Soumya?
For grading the disease.
Nab? Yeah, Dr. Soumya, please talk.
Ma'am, so that we can decide upon the adjuvant therapy, whether chemotherapy or additional radiotherapy is necessary.
Perfect. So we do the molecular typing after the surgery, post-surgery, in order to guide us about the adjuvant treatment. So we are basically doing the risk stratification in here, whether this patient is a low risk or an intermediate risk, or it is a high to intermediate risk, or is it a high risk. Before we used to do it only on the basis of grading of the cancer. But now grading is not important. Because even if it is grade 3, which is high grade endometrioid cancers, they behave well at times based on the molecular typing. So they have done the risk stratification based on the molecular typing now. So without that, we cannot decide, the adjuvant treatment. That's why we do. It is nothing related to the genetic diseases, Dr. Hamada. It is related to the risk stratification, which group she comes under, and then what adjuvant treatment we are going to recommend her. That is why the molecular typing is important. Once we do the activities, you will understand. So based on that, she would come under intermediate risk. Why she comes under intermediate risk, you will understand in some time. So now, because of this, we recommend an adjuvant treatment for her. So your treatment was almost partially right, Dr. Fatima. that you recommended a brachytherapy for her. To be specific, that we have to give her vaginal brachytherapy. So basically, the vaginal brachytherapy is just a local form of radiotherapy. You don't have to go into the details because you will not have much of time in there. So the vaginal brachytherapy is something that we are going to offer her. Not offer, consider. Where we still need to discuss this with a team of specialist doctors. And beautifully, you mentioned communication with the colleagues. You tried mentioning everybody on the board. So to get a full marks under communication with the colleagues, you have to mention everybody: consultant gynecologist, cancer specialist, radiologist, tissue experts, cancer nurse, Macmillan team. So this will constitute your cancer board. So we are going to have the discussion with them, which you told, and then we discuss this vaginal brachytherapy in detail for her, because she comes under intermediate risk because she's MMR deficiency. And not just MMR deficiency, she has got stage 1B and MMR deficiency. And then you put her in touch with counselors, support groups, and fix an appointment plan with the consultant, and give her the follow-up plan. If she develops any new symptoms, she has to come back to us immediately. Give her the patient information leaflet. And since her BMI is less, sorry, it is on the it is on the heavier side, you have to talk about the lifestyle modifications as well. That is very, very important. Okay, so understood now. And don't talk about any second look surgery. That's not required. Okay, don't talk about that we need to remove the lymph nodes and all of that. So here, only thing is that when we would have done her staging laparotomy, we would have done the total laparoscopic hysterectomy or total abdominal hysterectomy with bilateral salpingo-oophorectomy, and we would have done the lymph node assessment, and we would have done the sentinel lymph node biopsy as well. So just because now the myometrum is involved, we're not going to offer her any second look surgery. Now her treatment would remain only the vaginal brachytherapy, that to prevent her from having the recurrence, having had a heavier BMI and having had a MMR deficiency and stage 1B. Understood, everybody?
Excuse me, Dr. Deepika,
Yes.
why isn't she a high intermediate group?
She's
And
not high intermediate group. She comes in the intermediate group. So that will do the activities. Then you
Okay.
will start
Okay,
correlating
okay,
it. Okay. Yeah. So any question from anyone? Dr. Bhuvaneshwari, this was your exam recall, right? Was it almost similar?
Yes, ma'am.
Yeah. And anything specifically your role player asked?
No, ma'am, nothing else. She asked whether the MRI was wrong only, ma'am. And the further management options.
Okay. So now do you agree with the treatment plan?
Yes, ma'am.
Okay.
Actually, in exam, I also included chemotherapy because I wasn't sure. So I included both radiotherapy and chemotherapy.
Okay. All right. No worries. So we'll discuss that now, that where do we include a radiotherapy, chemotherapy, and where do we talk about vaginal brachytherapy, where do we talk about external beam radiotherapy, all that would come now. So if any question, this is a recent recall, Dr. Hamada, this year, I mean, May exam. Yeah. All right. So let's move on with some activities now. So what was the need for updating this FIGO staging of endometrial cancer? Anybody? Why was it updated in 2023? Was it really required? Yes or no? No one wants to talk now.